Hello and welcome to the Auditing Antics podcast. So, Michelle, today we're finally back in our offices. Well, we got home Monday, but I posted on LinkedIn over the weekend if you didn't catch it that we were in Beaufort, South Carolina. So, we have some trips this summer planned where Michelle and my parents are going to travel to where I'm going with some of my family, and
hmm
we get to spend some quality family time together.
Yeah, it was a lot of fun. Um, Exhausting with little Riley. He sure keeps us on our toes. I mean, he's
Yeah.
just into everything, but lots of fun, good family time, getting to spend time with our family in South Carolina. Exhausting, but worth the short trip.
Yes. Riley, my grandson, it was his first time going into the ocean, so or to the beach in general. So he absolutely loved it. He is a busy little body. He never stops moving ever, ever. He's just I've
Even in
never
his
seen
sleep.
a yes, even in his sleep. I've never seen a kid so curious before, but he absolutely loved the ocean and the water, and just seeing how he reacted with the way that the water like pulls back out. And it's fun to see the world through new eyes, basically see
hmm
him experience things for the first time. So
Yeah.
that was fun. We got to spend time with our aunt and uncle and cousins and family that live in the area. So it's a beautiful place. It's not a bad
It
place to
really
have
is.
family to go visit.
Not at all. Not at all.
Yeah. Now, speaking of vacations and different locations, we're actually
Oh,
talking about locations today
that's a good
in
point.
yes, in terms of telehealth services. And I'm sure we've mentioned this before on the podcast just when we talked about telehealth, but this is something that still I get so many questions about. And I just was doing a presentation recently and still had someone come up and say, I don't really believe what you're saying about location. How is it that, this is a typical workflow and you're saying that it's not compliant? So, the reality is a lot of people are still getting it wrong. A lot of people still have, providers that are using telehealth, I would say, more out of convenience, which isn't
Yeah.
always a great thing. And we've got to make sure that we have locations set to have compliance to then have a reimbursable service.
Yeah. And I think that it's a common misconception out there that it only matters where the patient is and not where the provider is. But in reality, we have to be sure that both are in check when billing for those telehealth services.
Yeah. And, I never will forget, I remember reading an article. It was towards the end of the PHE. It was definitely when the states were starting to expire their waivers related to licensure. And there was a female practitioner that was interviewed by, I don't know what news outlet it was, but she basically was saying how great telehealth was. And now she's been able to go around and visit every beach, in a certain area of the US. And it's like, I'm listening to that, thinking to myself, well, do you have licensure in all of these areas? Are you paying attention to what the compliance rules are, the legal regulations are? And like you said, a lot of people are not. So before we jump into what is the correct way to be doing this, I want to just give a little context from my perspective as to why this is still a problem and still happening. And I really find in my conversations that it's stemming back to the PHE, where we did have a lot of different states that put waivers in place that allowed practitioners to practice across the state line as long as they had primary licensure in another state. Now, it didn't work that way across the board for every state. Every individual state and governor made their own decision as to how that was going to work. At the time, I remember going to this particular website where we could see every state listed out, what the waivers were, what the requirements were. Some of them, for example, made an expedited process for a telehealth license where a provider could get through much faster, and then others just allowed the practice to happen. But where this has all become a huge disconnect is the fact that a lot of those waivers started to expire in 2022 and definitely expired in 2023. So
Mhm.
now we're left with everything going back to how it was prior to the PHE, but our providers and even patients are only remembering those flexibilities.
Well, they remember them because that's what was convenient for them and
Yeah.
what made their life easier, and it's gonna be hard to well, we've seen it is hard to see that switch back to what
Hmm.
it's supposed to be because I think a lot of people were like, "Oh, these are just going to be here to stay." Life was that way for so long that it was just I think assumed that these things were going to be around forever.
Hmm. Yeah. So essentially, they make permanent policies, or, everybody in the busyness of the industry, we always have the issue too, where somebody hears something one way to begin with, and then they never look at it differently, and it becomes that constant battle. So
Yeah.
that's definitely been happening as well. But when we look at location and look at the sources, so we can say all day that the patient, the provider has to be licensed where the patient is located, and the provider has to be licensed where they are physically located at the time of that encounter. But let's talk a little bit about the why behind that, because I don't want people to think that this is just our opinion. There's actual rules and regulations that go behind this. And, one of the biggest ones, I like to utilize the website, and I'm just going to look it up here quick, ccp, cchpca.org. And that website is great because you can go in and you can look at a federal level at what everything is in terms of telehealth, how everything is set up, but you can also look at state levels as well to see what the different requirements are. And I think the reason this gets confusing is because we have to look not only at payer policy, but we have to look at state law. And the states will dictate, scope of practice. We've talked about that before, what a particular licensed individual is allowed to do within their state. So, in that same way, no, we aren't legal, but this directly impacts whether or not you have a service that you can be reimbursed for. So, Michele, from your perspective, are you typically, when you're going in and auditing, for example, are you seeing issues around documentation, or are you not seeing any documentation that's helping to validate this part?
So there's a couple issues that I come across when auditing the telehealth services. So first is, as you mentioned, no documentation. They're relying on that visit type to say, hey, this was telehealth. No patient consent, nothing. You don't know, is it audio only, was video involved, so no documentation. The second issue is there's partial documentation. And a lot of times you'll see, like, for example, patient was located in Florida, but so they have consent, they have the patient was located in Florida, they have, the equipment used. But what this doesn't tell us is for those payers that require either place of service 10 or place of service 2, you cannot accurately select those place of service. Now, I recognize some payers do say we only want place of service 2, we only want place of service 10. I recognize that. However, that that is a lot on your team to constantly like validate each individual payer policy, that's quite a bit. I know things like Epic and such can automate that process, but this is why we recommend a standard where all the requirements that may be needed are met so that you have all the information necessary for billing. And I know I say this a lot, but sometimes the feedback will be like, well, that seems a bit particular particular, or that seems like a lot, but that's what's needed to accurately. We need to know if it was audio or interactive with the use of video. Some payers are not allowing audio only anymore, for
Hmm.
example. We need to know where the patient is located so that we can properly apply place of service. So we're not even talking about like that's not even talking about some of the more particulars of the compliance things, but even just to accurately bill for the service.
Hmm.
So still tons of deficiencies. And the last thing that I want to um, touch on is the inconsistencies within documentation. So they have this great template for a telehealth service that says patient is in their home in the state of Florida, because that's where I am. But then you're in the HPI, you're reading, and they're like, the patient is back home in Massachusetts. And it's like, but your telehealth statement says they were at home in Florida. Uh,
Hmm.
so those are some of the biggest issues I see. And I think that last one is sometimes the most concerning for me because that means they're not even reviewing the documentation or paying attention
Hmm.
to, with their use of templates, for example. So
Yeah.
those are my biggest documentation deficiencies.
Yeah, I agree. Well, and that's a good point too, because location isn't just us looking to validate are they in the state with licensing. It also is, like you said, home or away from home.
Hmm.
And I know that in some of my reviews where I've identified more of that legal concern and issue about patient location, provider location, it's actually been when they do fill out a telehealth statement and they say, patients located in North Dakota, providers located in Florida. Well, is that provider licensed in North Dakota? Is that provider licensed in Florida? And there is some variation there, and I want to speak to that a little bit because there is, if you were to dig really deep into this, the way that this works is when we look at the state level, each of the states are going to determine what the requirements are to practice in their state.
Hmm.
So, number one, the telehealth encounter is considered to be occurring based on where that patient is physically located. So, if we have a patient who is primarily in Massachusetts, but they go to Virginia for college, when they're in Virginia, they can't continue the regular services if that provider is not licensed in Virginia. So that has, I think, been more clear. But where it gets more complicated is that some of the states will also dictate that the provider has to be located in the state and licensed in the state if they're caring for a patient in that state. So that is where it will have variation because it's going to be very state specific. You want to
Hmm.
look into that one website that I was talking about there where you can actually break it down and look to each individual state. But then we have to take it a step further because apart from the state laws and regulations, we have to look at payer policy. And I was actually reading a telehealth policy working on an audit this morning where the payer's telehealth policy stated that it was in the state of Arizona, and it said right in the commercial payer policy that the patient and the provider had to be located in Arizona, and obviously the provider had to be licensed in that state as well. So, one step beyond we have to look at malpractice insurance. And I think a
Mhm.
lot of people forget about that. That's one thing that, when I hear Terry Fletcher talk about telehealth services, she's always talking about that. Your insurance policies may not even have coverage for certain situations, depending on what's been included related to telehealth. Lastly, the organization needs to have a policy.
Mhm.
Now, I say that with a grain of salt because some organizations have policies that are not compliant, and that's concerning. For example, I've heard of organizations having a policy that says that as long as the patient's primary residence is in that state, you can go ahead with telehealth even if they're visiting another state at the time. Things like that are not okay.
Mhm.
Lastly, we have to also look at the US borders. And this is something that gets confusing as
Yes.
well because the
Yes.
provider and the patient have to both physically be inside the US.
Yes.
So, Michelle, I know you've worked with this a while back as well
Way
at your
before COVID.
organization.
It
Yeah,
was even
before
before
COVID.
COVID was a thing. The
Yeah.
provider was going out of the country back to their home to visit family, and they wanted to be able to continue to build telehealth services from outside the US, and they weren't too pleased when they were told no, they could not do that.
hmm And
Sometimes
same
you
with
just need to
patients.
take vacation and take vacation.
Yeah, exactly.
Like,
Yeah. Well, I
uh,
had that question recently because a patient had been accepted into a program. I think they were going over to Italy for 6 months as a graduate type program, and they were receiving behavioral health services. So they wanted to continue therapy, all of those things while they were overseas. And it just doesn't work that way. You have to be within the US. And that particular scenario causes a lot of issues with other services as well. That's why things like CCM, RPM, when people hire external companies to do that for them, if those companies have people located overseas, then it's not considered to be a reimbursable service because it didn't occur within the US. So out of the country, completely out of the question. State levels, you really have to dig in and look, unless an organization's going to make a policy across the board, which that's what I would recommend because there's so
mhm,
many variables there.
yes.
But we definitely still have that large issue of providers wanting to go on vacation and continue. And one thing we didn't talk about this before, Michelle, but I just thought about was with direct virtual supervision. And that's not necessarily in the same bucket as telehealth, but
Mhm.
there's a lot of providers that now are wanting to use that new CMS permanent adoption of direct virtual supervision as a way to be out of the office, still bill for everything under their NPI number. And that causes even more issues. And again, when I had that conversation recently with an organization, they wanted to do that to cover and still bill while they were on vacation. So they weren't even going to be in their primary state. They were going to be elsewhere and they still wanted, infusions, the office visits, everything billed under them under incident 2 with direct virtual supervision, which is just a recipe for a disaster.
Yeah, so what are they gonna do? Sit out on the beach with their with their
Well,
stuff for direct supervision? Like, because they have to be available.
yeah, and I should clarify in case people have not dug into direct supervision. The reason that will not work is because for that to be compliant, like Michelle said, they have to be readily available, but this has to be also done through video, and we have to think about a HIPAA compliant platform as well.
Yeah.
So it's not something where you could just call your physician who's on the beach and say, hey, we're having this emergency in the office. how do we handle this, looking for directives, they have to actually be able to connect immediately and be available immediately. Who knows? Maybe they're on vacation and on a roller coaster or out
Yeah.
on a beach without service or so windy they don't hear their phone ringing. So there's
Or
a
they
lot
lose
of
service
variables.
mid supervision.
Yes. Yeah. Yeah.
I I don't know. I I know it can be done appropriately, but there are just certain things that I feel like don't belong over telehealth. And
Mhm.
I know we've talked about some of those recently. But so we've talked a lot about like the legal and things like that related to telehealth. So when it comes to documentation, a lot of these things are obviously best practice documentation recommendations, but can you give some of your thoughts on things like template use, and should there be requirements within the template that the provider has to update each encounter, or would you accept, like, for example, a copy forward telehealth statement? So some best practices and things that you're seeing and recommending related to the actual documentation of the telehealth services.
Well, when I'm reviewing those, I'm really looking at a statement and the rest of the notes separate from each other.
Mhm.
And what I mean by that is that I am looking to validate different information out of the telehealth statement than I am out of the body of the progress note. So within a statement, it is okay for that to be heavily canned. That could
Yes.
be in a copy, bring forward. We have a lot of people using smart phrases, macro
Mhm.
statements, things like that. That's perfectly fine, but the information does have to be updated specific to the patient. So when I'm looking at a telehealth statement, what I'm looking to validate is the modality or the way that that encounter was performed. So audio only or interactive with video. Using those words, telehealth, telemedicine, virtual, none of those things definitively mean video was used. So we need to
Mhm.
know audio only, interactive with video. We also need to have reference. I prefer reference to still be there regarding patient consent. There's a
Mhm.
lot of back and forth, but I've had to defend different organizations in audit processes where it really is best practice to just put patient consent in your statement. Then, when it gets to location, to your point, two things. If a practice does not want to put in the specific state location, for example, they just want to say home or the patient's at work, things like that, then they still have to be validating that. Because remember, if there's a concern related to that, there can be a deeper dive when it comes to an audit or an investigation where they're going to be looking into, maybe the provider's personal information. I've seen many instances where an investigation is occurring and they're looking at the flights that somebody has purchased and things like that. So we have to keep in mind that that is the level these particular reviews could go to depending on
Mhm.
the type of scrutiny that's happening. And then another thing that people are not always realizing is that some of the states are wanting the platform that's being used to also be put into the documentation. So I just put that into my recommendations for the macro statement where you're saying,
Mhm.
for example, use doxy.me for this HIPAA compliant encounter. But a lot of that, again, can be very canned because they can update
Yes.
the type of visit, they can update locations, and the rest really does tend to remain pretty much the same.
Mhm. I think for me, it's definitely a situation where I would recommend template use versus relying on copying forward that information. I have some clients that require a completely unique statement to that date of service, and I have some that don't care if it's copied forward. But like I said, these are a lot of things that we refer to as best practices, and not because there really isn't anywhere that verbatim states what has to be documented to support
Mhm.
telehealth. And I think that is where a lot of people take issue with some of these recommendations. And what they have to remember is the why behind these things needing to be documented. It goes deeper than just a documentation requirement. It is a legal issue. It is a payer policy issue. It's, even just to get the service billed appropriately based on modifiers or place of service.
Mhm. Yeah, and it's one of those things as well to that point where you essentially have to piece together all of the requirements that we're talking about. So
Yeah.
they're not in one place. We can't go
Mm-mm.
into one policy and see, document these things in a statement. We're looking at all of the requirements in general and piecing that together so that in the event of an external audit review, you have everything that's needed. And,
Right.
there's so many times that I've reviewed telehealth services, even from the payer's perspective on some of those projects, where they constantly bill place of service 11, but yet the documentation is showing that it was telehealth in the patient's home. The payer does require O2 or 10 as the place of service. So there's a lot of ways that that can, become an issue in an external review, just apart from making sure that you have the education internally, because your providers need this education, your staff needs this education, patients need this education. There's a
Mm-hmm.
lot of times where I've had clients where patients don't understand, and then they end up in a situation where they need a medication or something like that, and they're not even in the state. And to that point, another thing we didn't talk about, and I'll just mention this briefly, but you also have to be aware of the different state laws related to prescribing medications. The DEA does have different restrictions in relation to controlled substances, for example.
Mm-hmm.
And I had a client at one time where it had to be a specific type of practitioner that was prescribing a controlled substance in the state of Florida. It wasn't just anybody with a telehealth license. You had to be, I believe it was a physician, and you had to have that telehealth license. And that came into play quite a bit with some of the patients that they had
Mm-hmm.
because of living in another state for part of the year, things like that. So, overall, the gist of today's episode is location matters, the patient and the provider. This is not out of convenience. This is not another way to offer travel, flexibility, any of those things to the providers that are working in your organization. And hopefully people will start taking a look. I know I talk about this every single time I present on telehealth. And, just this last one, when I was questioned on that, the one person who was asking, their spouse actually works in a very large hospital system, well-known nationwide hospital system. And they're like, well, how is this not compliant if this system is allowing it? And it's like, okay, well, somebody must not be looking deeply at that requirement. Or it's like the telephone game too,
Yep.
just
Mm-hmm.
because he said that to me doesn't mean that their legal team said something different or their compliance department said something different. It's the general understanding amongst those who are providing the care and setting up the telehealth services. So
Yeah.
a refresher is often needed.
And this is a reminder that just because somebody else is doing it, you still need to do your own research. Because even if your provider has gone to some conference and somebody stands up there and says, "You can do this."
Hmm.
Wow. How many of us have dealt with those messes? Ay, ay,
Hmm.
ay. But do your own research. Don't just take somebody else's word for it. Like Stephanie said, it varies based on state.
Hmm.
So, and even apparently all the way up to the malpractice insurance
Yes.
coverage. So it could vary widely. Um,
Hmm.
so you can't just do what your neighbor's doing and think you're going to be good.
Right. So take a look if you and your practice are rendering telehealth services. Sometimes now it's just a small volume. It's not a lot of patients that are getting telehealth. And then others are mainly changing to that structure where almost every encounter is telehealth based. I'm finding more issues with the larger organizations because it kind of got out of control over time. But make sure you're checking, do your due diligence, look over what your state says. If you have a situation where a provider says, I've got a lot of patients who go to Florida or Arizona for
Mhm.
winter, things like that, go in, take a look at those states. What do their requirements say? Because those legal requirements are going to affect whether or not you should be reimbursed or should keep that reimbursement. So
Mhm.
we've got to be careful and check all areas and keep refreshing. It's not one thing that remains the same all the time. Telehealth has gone through a lot of changes and there's a lot of misunderstanding. Do the check, make sure you're good to go. All right, so we will end it there for today. Um, Next week, I'm not sure yet, Michelle, what we're going to be reviewing. Sometimes I have these moments where I'm seeing issues a lot and it comes right to mind and I say, okay, we've got
Mhm.
to talk about these things. These are the next 3 episodes. We'll come up with something by next week. As a reminder too, I have had some people that have sent messages in. So if there's any topic you would like us to cover, you can always reach out to me through my website, stephanieallardconsulting.com. You can message one of us on LinkedIn and we'd love to hear some feedback. You can always make comments too on different episodes, regardless of where you follow. I get notifications. So let
Mhm.
us know if there's something that you would like us to cover and we would be happy to look into that. All right, so have a good rest of your week, and we will see you back next week.